has been, I'll dive straight down into the topic. We'll start with an approach to a vomiting child and then proceed from there depending upon the time frame. This 5-week-old male infant, mother says, started vomiting about 2 weeks back uh, and vomited so forcefully recently that she's been sprayed, and this has been happening frequently. She also complains that the urine output has decreased. So when a child comes like this, we have a few things to ask for. Sorry, we have a few things to ask for. The more first and foremost is to identify whether it's a bilious or a non-bilious vomiting. I will confine myself to surgical topics because as medicos, you are the bosses as far as medical causes are concerned. We also need to identify whether it is painless or it is associated with pain. Is the child eager to feed or is it refusing feeds? Is it been associated with constipation? Is there any blood in stools? Is there progressive decrease in urine output as the child becomes progressively irritable or lethargic? Putting the combinations of these, we will be able to come to a reasonable solution. So at the same time, when examining the child, along with all the rest, we'll be looking at the abdomen, particularly to look for distension, whether there's any upper abdominal distension, or is it a diffuse distension? Are there any visible gastric or intestinal peristalsis? Any visible bowel loops? Is tenderness and rebound rigidity, is it present? And are palpable bowel masses or loops noted? Here, I'm going to show you in the upper abdomen, you are able to see classic visible gastric peristalsis, which is progressing from the right and going down to the left. Compare this to this child, where there are already multiple loops which are visible, and it seems to be going from up downwards. There is some respiratory movement also seen, but you are able to see the step ladder pattern. This is visible intestinal peristalsis, and this was gastric peristalsis. Palpation of an olive is now becoming a lost art. However, if you keep a child on the mother's lap, warm and comfortable, maybe give 5 to 10 ml of dextrose water, stand by the left side of the child, use your left hand, palpate the edge of the liver, and just dive deeper, push your hand deeper under the liver, we should usually be able to roll the olive. However, if the child is not quiet, it is difficult. USG is more often used nowadays as the diagnostic mode, and we also need to assess dehydration status when the child is, how dehydrated the child is, and of course all the medical signs to differentiate it from a medical problem. Sonographic signs are plenty: the target sign, the cervix sign, and the antral nipple sign. Here's the antral nipple sign, which is clearly seen. Here's the target sign. The length of the pylorus more than 15 to 17 millimeters, and the thickness of the pylorus, which is more than 4 millimeters, is considered diagnostic of IHPS. Here it is better seen. This is the mucosa, which is hyperechoic, and this is the serosa, which is hyperechoic, and the hypoechoic muscle in between. Initial management is to put in an NG tube, empty the stomach. Fluids recommended are usually N/2 DNS with a rate up to 150 ml per kg per day, bolus with normal saline depending on dehydration, and potassium to be added at 20 milliequivalents per liter. Antibiotics are not required. Alkalosis corrects itself. It is important to keep these children nil by mouth as soon as the diagnosis is made while the referral is being done, as it prevents more vomiting and loss of fluid. Pyloromyotomy is the surgery of choice. However, we do not rush to pyloromyotomy as soon as we receive the child. it is more a medical emergency. The electrolyte collection and the metabolic alkalosis correction takes precedence over surgery, and only after those things are corrected, child is operated. With laparoscopic surgery, the scarring is quite minimal, and the child can go home in a day or two after the surgery. However, consider an alternative scenario with similar child, but coming now with bilious vomiting. It is now mandatory to rule out malrotation. Malrotation is considered by all of us as a ticking time bomb because because of the volvulus it can undergo, and delay in surgery can lead to massive gut loss. By age wise, there's more than 50%, half the cases of malrotation and three-fourths of the cases of malrotation present by 1 year. Therefore, a high index of suspicion is required in this period of time. Hyperacute presentation occurs in about 5%, which indicates volvulus neonatorum, where no time should be lost at referral or surgery. Most important cause of high intestinal obstruction, because delay can lead to loss of the entire jejunum, ileum, or half of the colon. And this child is unsalvageable in our current scenarios. How do we suspect malrotation? Bilious vomiting in the presence of visible gastric peristalsis, we have to have a high index of suspicion. That is the most important thing. And volvulus neonatorum, child may have distension of abdomen, and the bowel mass is usually palpable and it is tender. Plain X-ray, the gasless abdomen is the omnious one where all the air has been absorbed because of there's no air going into the bowel because of the complete obstruction. Here's a child with an upper GI contrast study which shows the DJ which is here should have been beyond this area, but it is now in this place. And in the next one, I will show you a video where you can see the volvulus. Here's the contrast which is going, you can see the spiraling or the spring coil sign. Ultrasound may also help in the diagnosis, however, it is not diagnostic. Whirlpool sign is suggestive of volvulus. The blue is the superior mesenteric vein, and this is the superior mesenteric artery. Normally, it should be seen in this place, but it has moved to the left. This is a surgeon's nightmare where a delay in diagnosis and surgery has led to complete gut loss. These patients are unsalvageable without home TPN and multiple surgeries. So early surgery, pre-op stabilization is done in early diagnosis. It can be skipped or should be skipped if volvulus is suspected and is done concurrently with surgery. That procedure is a surgery of choice. Now consider an older child who has come with passing brown colored stools or blood in stools. The child may be irritable with or without incessant or irritable crying, and may or may not have nonbilious vomiting. If the child has had a similar episode 2 months back, as in this case, intussusception is unlikely because intussusception doesn't go away on its own. If it is the first episode, then intussusception would be high on the list of differential diagnosis. In a child like this, the differential diagnosis would be intussusception, a bleeding Meckel's diverticulum, enteric duplications with ectopic gastric mucosa, and of course, malrotation also. Ultrasound of the abdomen can diagnose intussusception, and therefore, in a patient with bleeding per rectum, an ultrasound is a more important test rather than a plain X-ray, as it is not so useful. Whereas in a child with bilious vomiting, and plain X-ray would be a more suitable first test. It can also diagnose or suspect duplication because of the gut signature. Meckel's scan is also useful. In this particular case that I have mentioned, the ultrasound was normal, and hence we requested for a Meckel's scan. A normal Meckel's scan will only show the stomach and some amount of the radionuclide in the bladder. as time progresses, the bladder is filling up, and as the child voids, the bladder has become empty. Stomach is still persisting. If after about 15 to 20 minutes we see another spot, a single spot you can see here it is, and at 40 it is more prominent, and it stays as long as the stomach is staying. It is Meckel's diverticulum. However, in our case, we had multiple such spots or one long spot like that, which is suggestive of a rare long tubular duplication. A Meckel's diverticulum, which is bleeding. Here you can see the blood dark in the bowel, whereas it is not so in the proximal limb. This is a duplication cyst, which also can have gastric mucosa, ectopic gastric mucosa, and can bleed, and this is an intussusception. However, we had one case of this long tubular duplication, which was almost 80-90 centimeters, and we managed to save the entire bowel. If on ultrasound we pick up in a similar child a target sign or a pseudo kidney appearance, thanks to this doctor who has managed to show the normal kidney as well as the pseudo kidney next to each other to contrast, we suspect or make a diagnosis of intussusception. Intussusception, if the child there are no abdominal signs and the child is not sick, we would proceed with a non-operative management. The protocol usually is to correct the dehydration, give an initial bolus, start on third generation cephalosporin and metronidazole as IV antibiotics. This is required before starting the procedure of saline hydrostatic reduction to avoid transmigration during the procedure. 3 minutes of pressure, about 90 centimeters of water. Usually the saline bag is kept above 3 feet above the child and no pressure is applied. This would help to reduce the intussusception, and this is done with ultrasound guidance. Not more than 3 attempts are usually done at one go. If the child has completely reduced, then we bring the child back, continue IV fluids, do a repeat check ultrasound after 6 hours or 8 hours, and then start the feeds. If there is a residual intussusception, we can give another attempt maybe 4 to 6 hours later. If that also fails, child will have to go for surgery. So I have given you various scenarios: a young baby with non-bilious vomiting, which is also hungry, a older child or a newborn with bilious vomiting, which can be malrotation, a child with bleeding per rectum. If it is painful, will colicky crying spells, it would be intussusception. If it is painless, may be recurrent, it may be Meckel's diverticulum or a duplication cyst. Going to a totally different level area, a 9-year-old boy is brought with sudden onset of left scrotal pain, which is severe, and parents say it started about 12 hours ago, and the child feels nauseous but has not vomited, and he has no fever. Mother also complains of swelling of the left side of the scrotum. This would be consistent with an acute scrotum. The most important and the dangerous diagnosis is testicular torsion. The other differential diagnosis of testicular torsion are given here, and the clinical clues that with epididymoarthritis, that is a known case of with genitourinary abnormality or recent viral illness may be present. If there is urinary tract infection, it may be related to that also. Idiopathic scrotal edema is, however, painless and there are no signs of infection. However, it is quite swollen up. Torsion of the appendix of the testicle is described. Blue dot sign is well described, however, hardly seen in our dark skin. History of trauma, if it is forthcoming and significant, should be taken into account. Tumor, inguinal hernia, and varicocele are usually more chronic pains. So, what is classical testicular torsion pain and symptomatology? We usually see severe unilateral testicular pain, can be associated with nausea and vomiting, and may have non-specific symptoms also to confuse us, and they may also give history of minor trauma or some physical exercise even though no association has been confirmed. The ipsilateral skin may be indurated erythematous. The left testis is usually lower than the right testis, and if it is higher than the right, we can suspect that it might be torsion. It is usually because of the foreshortened spermatic cord. The testis may or may not have a horizontal orientation, and cremasteric reflex is usually absent. However, if both sides cremasteric reflex cannot be elicited in a child, then this test is not so useful. Prediction of viability of the testicle is difficult. However, it is reported that if they present within 6 hours of onset, which I have not seen in the last 20 years or so, the surgical exploration gives a 90 to 100% salvage rate. If it is between 12 and 24 hours, it's only about 50%. And if it is 24 to or beyond, it's less than 10%. However, given the importance of the organ, we have to suggest, even though there is so much of uh, description I have given on examination and we have to suggest immediate surgical exploration if the child has come in a salvageable state, that is less than 24 to 48 hours. So that is what is suggested by most of the guidelines also, that immediate surgical exploration if it is consistent or highly suggestive of testicular torsion. If there is questionable diagnosis, they would advise Doppler ultrasound, but they also give a caveat: do not delay surgical referral for imaging. So unless OPD setting or a clinic has an associated ultrasound, it is not feasible or it causes delay in presentation or referral. Absent blood flow may not always be is always present with torsion, but the peripheral tissue may show increased blood flow, which can be mistaken for peritesticular blood flow may be mistaken, and therefore there might be some blood flow shown around in the scrotum, which is misdiagnosed. Therefore, Doppler ultrasound, unless done by an expert who is with children, it is not as useful as described in literature. Immediate surgical exploration, if it is before 48 hours, and if it is beyond 48 hours of presentation, go ahead with the ultrasound or whatever, and then do the referral, because in any case, testicular salvage is very unlikely. This is a child who came to us about 3 weeks back. First, they found that ultrasound was done elsewhere. There was some flow. The 24 hours later, the pain was persisting, so they got another ultrasound done. That time it was unequivocal, and a third ultrasound was done on the third day, which also showed some blood flow, but there was heterogeneous ecotexture of the testis, at which time it was referred. And this is a torsion of the testis. It is already black. This would have been torsion of the testis from the beginning. Opposite side is usually PEX, that is, an orchidopexy is done of the opposite side, because 80% of these cases, the potential for torsion is bilateral in up to 80% of the cases. This is the bell clapper phenomenon, which if is present on one side, which predisposes to torsion, is in 80% of the times present on the opposite side also.
Sorry, sir. 5 more minutes, sir.
Yeah, I will be completing quick. As a request from the Professor Angavilo, I thought I will just cover quickly, even though the video and other things are not my own. Non-suture wound closure would be of much use in the clinic. However, the utility of this is in relatively small, clean wounds where the edges are clean and there is no tissue loss or tension in bringing these two edges together. These can be considered, absence of these can be considered contraindications. It should also not be bleeding overly. It should not be over mobile areas like joints, and the patient should have presented within 6 to 12 hours. Delayed presentation also, it doesn't help as much. So what are these non-suture wound closure techniques? Simple lacerations with only slightly separated wound edges can be used with adhesive strips, what are known as steri strips, which are commercially available, a little expensive, or with micropore, one can fashion their own steri strips. The wound edges should be cleaned, preferably with saline, a jet of saline, made dry. Apply benzoin, tincture benzoin around the wound, but don't put it inside. Afterwards, the child will run away from you. And bring those two edges together. Place the strips with some space in between. So the each strip should be about 3 millimeters or so. And you give a gap of another 3 or 4 millimeters. Place another strip and close the wound. Keep dry for about 72 hours. If the stickiness is not so great, therefore either with steri strips or with micropore, and therefore if it is wet or it gets wet, these would open up and the scarring would be pretty bad. The other alternative is to use the Dermabond glue or the tissue adhesive. It is monooctanyl cyanacrylate, basically what super glue that we use commonly in households, but this is medical grade and therefore costs about 1,000 times more expensive. Used on wounds with clean edges. And again, it should not be under great tension. Minimal tension is acceptable, but it should not be under great tension. It is best for wounds less than 3 centimeters. For wounds greater than 3 centimeters, if the subcutaneous tissue is sutured, then it can be used. But if one is suturing that, one may use as well suture the skin also. It is not to be used on mucosal surfaces. It should be, the eye should be protected. So if it is being used in the chin or forehead or something, pad the eyes and apply ointment into the eyes and then pad the eyes so that it does not get into the eyes. Do not allow glue to enter the wound itself, then it will not heal because it acts as a foreign body. The exact procedure I will I'll show in the next one. And it need not be removed as it is. It will fall off in a couple of weeks. This is a video I have borrowed from University of San Francisco. So this is the Dermabond, and you can use in small lesion like this. So as I said, you should get both these edges of the wound together and then apply it. It should not be applied like this, like pasting two sheets. If that is done, there will be a foreign body reaction. It also causes heat. So you can apply some neomycin or something like that ointment around it. And get the wound edges together. So you require one assistant to do this. So there are different types of applicators. So read the instructions because each of them have slightly different ways of this one. In this, you are breaking the glass inside. In another one, it will be a twist. There are different applicators. And you first apply it together, then you start applying around, and then you start applying again. So 3 layers are applied with about 20 to 30 seconds between each layer. So first layer, give a gap of 20 seconds to 30 seconds to dry. Then second layer, then the third layer. And in 1.5 to 2 minutes, the entire thing is dry. And you can leave it as it is. So next, I thought I would add a few slides on foreign body ingestion, even though it has been covered. This 3-year-old child is brought with a history of swallowing a coin about 3 hours back. What would we do? This is straight from NASPGHAN guidelines. We would ensure that the child is not sick. If the child is not sick, then we would take the child up for an X-ray and identify. Otherwise, we will stabilize and then take the X-ray. Usually, X-ray would tell us what the type of foreign body is it and where is it. The child is having drooling, dysphagia, respiratory compromise, then of course urgent endoscopic removal is required. And if it is asymptomatic, For example, in a coin, for example, in a coin, one can wait for about 24 hours, even if it is in the esophagus, and if it has not gone down, then it can be removed. However, in case of gastric foreign body, then if it has passed into the stomach, usually, and the child is asymptomatic, usually it can be left alone and a repeat X-ray or ask the parents to strain the stool and see regularly, and one can identify that it has come out. Otherwise, after 2 to 4 weeks, it can be removed. If it does not come out in 3 weeks, usually it means that there is something wrong in the passage. If it is small bowel, again it is the same. It is similar to stomach. However, we may require surgical removal in these cases if it has not passed out. And usually it is associated with either a stricture or a Meckel's or something like that underlying. This 8-month-old child was brought to us with a history of swallowing a battery about 4 hours back. X-ray was taken. And these are the guidelines. However, most common scenarios which would come to an office practice are the child is stable and therefore can be referred for immediate if it is esophageal and it is stable, it is referred for immediate removal. If it is gastric or beyond and the child is less than 5 years and if the child is greater than 5 years and the foreign battery is less than 2 centimeters, the child can be observed under outpatient. Usually after 2 days, we take a repeat X-ray, make sure that it is passing along, and if after 2 weeks it is not passed out, then we need to remove it. However, if there is any suspicion of symptoms, then it needs to be removed immediately. Here's this child which came at 4 hours. It went to the primary the pediatrician who has taken an X-ray and referred it to us. Child reached us after 31 hours. This was the X-ray. The lateral one shows the step beautifully, showing that it is the button battery. It was about 12 millimeters, and here you can see the rim sign. Since the child was asymptomatic and it was referred for endoscopist, the endoscopist did it the next day morning, and this is what they removed, and it was removed uneventfully. So stomach, and it is non-progressive, it should be removed. Or if it is more than 15 millimeters, 20 millimeters, it should be removed as early as possible. Sharp objects on ingestion in the esophagus, urgent removal. If it is gastric, it should be removed urgently unless it is very short. Whereas if it has gone beyond the stomach, then clinical follow-up, if they are asymptomatic, is more suitable.
Sorry, sir, one more minute. Sorry.
Yeah, this is the last slide. This is our data of 150 cases over a period of 3 years. We have had only 3% of surgical removal required. This only goes to show that if it passes beyond the stomach and it's not even button batteries, they invariably come out even if they are sharps or button batteries. This was 8 and 38%. Many thanks to my patients and parents for their who form the majority of